Welcome to today's webinar. County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute. This webinar is brought to you thanks to the contributions of colleagues and partners in Wisconsin and across the nation, with support from the Robert Wood Johnson Foundation. It is produced in collaboration with Healthy Places by Design, an organization that advances community-led action and proven strategies to ensure health and well-being for all. The University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Dejob since time immemorial. UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. This webinar will be recorded. All speakers' views are their own. Guest bios and slides from today's webinar are available on our resource page. We will share a link to the resource page when the webinar begins. Stay up to date on all things CHR&R. Find us on Facebook, Twitter, and LinkedIn. And if you haven't already, sign up for our newsletter by scanning this QR code with your phone's camera. It's the best way to find out about upcoming webinars, our podcast, and our latest tools and resources. Your facilitators today include our host, Erica Burrows-Girardi, with support from CHR&R Communication Specialist, Colleen Wick, and the Collaborative Learning Director from Healthy Places by Design, Joanne Lee. We invite you to continue the conversation immediately after the webinar in our discussion group. Joanne Lee will be our lead facilitator. And watch for a chat from Colleen for details on how to join the group after the webinar.
Welcome to Public Health 3.0 and the Future of Public Health featuring Dr. Sandro Galea. Hi, I'm Erica Burrows-Girardi, and I am so excited for today's webinar because we're going to be talking about what a modern public health system needs that meets today's challenges. What does that look like, and what do we need? Let's start by sharing why this is so important to us here at County Health Rankings and Roadmaps. We imagine a health system that advances the social determinants of health and prioritizes community wellness, healing, and mutual accountability. Our systems cultivate space and time for creativity, innovation, and joy. And the most important part of this belief is that we're all in this together. You and I, we're all in this together. CHR&R's webinars reflect the values that we hold as part of the University of Wisconsin's Population Health Institute. Values of collaboration, integrity, excellence, innovation, inclusion, and courage. And these are the values that we aim to model throughout the webinar, and we hope that you will as well. With that, I want to introduce you to the team that's going to aid in your learning experience. Let's start with Joanne Lee with Healthy Places by Design. Hi, Joanne.
Hello. Hi, Erica, and hello to everybody in our audience. Really excited about today's webinar. I know we're going to learn a lot. Everybody out there, I just want to invite you to join the conversation and engage with us during the webinar, in particular during the Q&A section. We've got some time reserved to field your questions. There's going to be two ways to engage with us during this live webinar. You can ask our wonderful guest speaker questions by using the Q&A box on your Zoom menu. We'll answer as many questions during the webinar, the live webinar, as possible. And you can also engage with other participants using the group chat box. So right now you're all introducing yourselves in the group chat. And I want to introduce Colleen Wick, who will talk a little bit more about how you can engage with us in the chat box.
Thanks, Joanne. Hi, everyone. Like Joanne said, I'll meet you in the chat. So please use the chat to share remarks or respond to questions we may ask you during the webinar. Please join us in making the chat space welcoming by adhering to these guidelines. Share successes, lessons learned, relevant resources, and links. Please engage in a respectful dialogue. Our chat conversations tend to be very engaging, if you can't tell already. So if they are too distracting, simply close the chat window. Again, if you have questions for the panelists, please use the Q&A box just as Joanne described. Now I will pass it to our technologist, Erin.
Thanks, Colleen. I'm Erin Schulten from our operations team. I will help you if you have trouble hearing or seeing the slides. So if you do, please hit your Q&A button. It should be at the bottom of your screen and send us a message there for us to help you. It's always good to be here with you all, and today's going to be a great webinar. Now I'll turn it over to our host, Erica.
Thank you so much, Erin, and thanks to the entire production team. You guys are so awesome. As public health practitioners and advocates, we must ask ourselves this question. What is the role of public health in the face of growing economic and racial inequality, political and racial unrest, and a changing climate? And if those challenges are not enough, public health is practicing in an environment of public mistrust in government and worker burnout. These issues may seem daunting and beyond the scope of our work, yet public health agencies have a track record of solving formidable challenges and can bring important skills and capacities to bear. Think about, for example, the COVID-19 pandemic. Okay, so we are still getting over the aftermath of that. It strained public health agencies and staff in unprecedented ways, but it also created and catalyzed opportunities for creativity and innovation in what public health agencies do and how we work. So I think about the expansion of telehealth. According to one study, the percentage of physicians utilizing telemedicine doubled after the pandemic, and trust in telemedicine grew. The pandemic absolutely catalyzed telemedicine, and it's here to stay. Even my dog has a telehealth vet. Some of your pets may have a telehealth vet as well. But the other thing I think about is partnerships, right? Like partnerships really, really evolved during the pandemic. The Navajo Nation, for example, and other indigenous tribal groups galvanized local organizations, in some cases, even starting GoFundMe accounts to ensure that residents infected with the virus received food and medicine. I think about this example. Historically, Black colleges and universities formed a partnership with Wells Fargo Bank to offer free COVID testing in neighborhoods that had high rates of transmission and in rural communities where testing was challenging to access. Now, perhaps some of you know of partnerships that would never have formed had it not been for the pandemic. So please share with Colleen in the chat, like some of those innovative partnerships or those innovative practices you saw happening because of the pandemic. Now, the challenge is, how do we move beyond those bright spots that may have happened in your community? How do we move to something that's more sustainable? How do we have sustained transformation? And that's where Public Health 3.0 is so relevant. It's a framework for public health practice that's shifting the way we do our work. Even though the framework has been around for about 7 years, it has become all the more relevant post-pandemic. This framework calls for a modernized public health infrastructure that takes an upstream approach where we focus on the drivers of our health decision making or the social determinants of health. The framework supports identifying root causes of health, but responding with equity. It recognizes that community is at the heart of what we do and that the public health sector expertise needs to be partnered with community expertise to create solutions that work. Public Health 3.0 offers 5 recommendations that the National Association of County and City Health Officials, y'all know it as NACHO, but they've laid it out so well. So I just want to kind of briefly tell you about these 5 components that NACHO lists up here. First, we need to embrace the role of community health strategists. So you may have already heard this already, but that community health strategist role is key when you are doing partnership-led efforts that transform public health. We need to cultivate cross-sector partnerships, engage with public and private community partners to diversify resources and foster collective action. This is one of the best ways to ensure opportunities for success. Public health departments should consider accreditation. Pursuing accreditation can help implement Public Health 3.0. Document successes with data and metrics. This is an area where we hear much community frustration, but the reality is that all of us need to be working toward making data more timely and relatable and more accessible for communities. We need to make sure that folks have access to clear metrics to document success in public health, particularly around the social determinants of health that some people feel is still like a fuzzy area to make that connection between that and health. So we need more data to do that. And this last one is going to be one that I'm sure all of you are going to agree with, but enhance public health funding. Now, if you're in public health, I know your funds are strained. We all are in this field of public health. So for all of the funders who may be joining us today, know that innovative funding models should be explored so that Public Health 3.0 can be fully implemented. Now, to learn more about Public Health 3.0, be sure to check out the resource guide that we will send out after the webinar. Most likely be tomorrow, but it'll definitely be before the end of the week. But we have a link to more information about Public Health 3.0, and so we would love for you to be able to explore that. Now, someone whose work actually lives out Public Health 3.0 is our distinguished guest, Dr. Sandro Galea. Dr. Galea is a physician, epidemiologist, and author. He is Dean and Robert A. Knox Professor at Boston University School of Public Health. Now, it's hard to really pin down any one area of expertise for Dr. Galea, but we know that he's steeped in the social determinants of health, mental health, and the consequences of trauma. So please join me in welcoming one of public health's most prolific thinkers and researchers, Dr. Sandro Galea. Dr. Galea, we're so thrilled to have you.
Thank you for having me. It's really an honor to be here with you.
So I want to tell our viewers today that they can read more about your bio, because if we actually read your bio sketch, we would not have a webinar. That we'd be talking about all of your wonderful accomplishments in writing. So make sure you go to our resource page, the resource page for the webinar. Colleen, will you check that out again? But it has a link to Dr. Galea's bio sketch. And then also, as a treat to you all, we have a link to a lot of his readings and his publications that's going to be on the webinar resource guide that will come out at the end of the webinar. Dr. Galea, I'm going to ask you, we're going to get into your interview in a second, but before then, I want to remind our viewers that we do have a discussion group that follows every webinar. And this is where you can unpack learnings that you're going to hear throughout our discussion today. So please plan to continue chatting with us about everything that you've heard today. During the introduction, you may have heard about the discussion groups. We know that it was a little low. Aaron did adjust for that. But if you did not hear, these discussion groups are facilitated by Joanne Lee. And they're always engaging. Some of you come to every discussion group, and I thank you for that. But it gives you an opportunity to share with others, but also learn from others as well. So during today's discussion group, we're going to be joined by CHR's very own Dr. Marjorie Givens and Michael Stevenson, and they're going to just help us unpack what we've learned today. So please plan to come. Colleen's going to chat out a link toward the end. Look for that link. Dr. Galea, I want to open my conversation with you with this quote that I read. In 2006, you were named one of Time Magazine's U.S. epidemiology innovators, and we talk about how important innovation is to public health, but they interviewed you in the magazine. Now, interestingly, and almost prophetically, you stated in that interview, once a virus hits the ground, there isn't time to contemplate how the public might react. We need to better understand why people react the way they do, and how we can positively influence their behavior. Um, that is wild that you said that. Then now we're talking about, we're like post-pandemic. I'm just curious about, there has been some criticism about some potential missteps around COVID-19. What what could we have done differently, and how do we influence behavior should there be another pandemic?
Yeah, thank you. So, I think to answer the question, we have to go back to what caused the problems of COVID. And I think a glib, easy answer is say, well, it's a virus. It's a novel coronavirus. But really, it wasn't about the virus. Really, what caused the problems of COVID were three things. Number one is our underlying social structures. Number two is our health before COVID. And number three is our disinvestment in public health. Let me just talk about each of them very briefly. We had social structures that embedded inequities that made some people more vulnerable to a novel coronavirus than others. For example, I'll use a very simple example. We knew before the pandemic what proportion of people were able to work remotely if needed. And the fact of the matter is, only in the top 25% of income were a majority of people able to work remotely. In the 75% of income, sorry, the lowest 75% of income, only a minority of people could work remotely. Well, if you have a novel virus where your primary strategy to mitigate its spread is to tell people stay home, work from home, when the majority of people in the lower 75% of income actually cannot do that, that means that the virus is going to spread more in that group, and you're going to have more consequences in the group. And that resulted in the early first year of the pandemic, the disproportionate burden of COVID infection, COVID mortality among people of color, among people with less education, among people who were less stably housed. It was directly linked to social structures that we knew about before COVID. Like, there was no mystery there. So that's number one. Number two is our health before the pandemic. We were a country that was sicker and living shorter lives than we had to before the pandemic, long before the pandemic. We had the life expectancy 5 years less than the next other high-income country. And when COVID hit, by January of 2020, we knew that if you had more underlying illness, you're more likely to be sick from COVID. So we actually knew that we were going to be sicker from COVID. So we knew all this. COVID hit, that's exactly what happened. Number three, we have been for the past 20 years, essentially, if you look at a graph of our spending during the pandemic, sort of going down on public health. So we've been spending less on public health. So we had social structures, we had underlying poor health, we underinvested in public health. All of that essentially set us up. And in my book, The Contagion, next time, I talk about how we were sitting ducks. We were sitting ducks for the consequences of the pandemic. Now, going back to that quote from, I guess, 17 years ago now, let's talk about we need to anticipate how people will behave. And people behave in very predictable ways. Like, if you need to work, otherwise you're not going to have food on the table, you're going to go to work, even if you're at risk for the virus. If you have uncontrolled hypertension, diabetes, you're going to be sicker from the virus. And if we as a society are underinvesting in public health, we're not going to be able to control public health. So all of that was entirely predictable. I wrote pieces and others wrote pieces in March of 2020 that in some respects may have been, seem like they're predicting the future as to what was going to happen, but it wasn't that difficult because we knew these things beforehand. So I think in the context of this conversation, what is important to remember is that the consequences of COVID were not because of COVID. COVID was the stressor, but the consequences were how we had prepared the society to deal with it. A metaphor, which I think might be helpful for people, is an earthquake metaphor. And, for example, these are both historical examples, a 6.8 Richter scale earthquake hits Tokyo, and a 6.8 Richter, same type of stressor, 6.8 Richter scale earthquake hit Iran. 20,000 people die in Iran, 8 people die in Tokyo. Now, it's the same stressor, right? The reason for the consequences is how houses were built to withstand the stressor. Similarly, the COVID is a novel coronavirus. That is what it is, right? It is a novel pathogen, no question about it. And we humans are all susceptible to it, right? But it's how we've built the world around us to be responsive to it that really matters. That's what makes a disaster. There's a stressor. A stressor becomes a disaster if we are not prepared to deal with it. And of course, to go back to your opening slide, this is where what have come to be called social determinants of health, and there's political determinants of health. I saw it in the chat. These are the forces that we need to invest in. We don't know when the next pandemic is going to happen. It may happen tomorrow, it may happen 20 years from now, but we do know the forces that are going to result in that pandemic becoming a deadly, devastating tragedy like this one was. And now is the time to fix those.
Right, right. I mean, so well said. And I love that example. Thank you. You know, if I was one of your students, I could listen to your lectures all day. Just saying. But, so that kind of takes me back to Public Health 3.0, because this model is created so we are prepared for these stressors that you're talking about. Tell us how Public Health 3.0, in your opinion, moves us toward equity, because a lot of those issues you brought up were like equity issues.
Yeah, so, I would go back a step and say, what is equity, right? So equity means that everybody has access to opportunity, that everybody has access to fair opportunity and resources that allow us all to live full lives, okay? And equity suggests not equality. Equality means exactly the same, right? Equity means that the distribution of those resources are fair. And by the word resources, I also mean health, right? Health as a resource. So when we have underinvestment, say, in the resources that make us healthy. So for example, we know that being born in a high opportunity neighborhood results in a 5-year greater life expectancy than being born in a low opportunity neighborhood. Now, I think we can all agree that the neighborhood we're born, we never chose, right? You happen to be born in a particular neighborhood. It has nothing to do with anything you do, which means I think we can all agree that it's not fair that our health is going to be shaped by something that we have no control over, hence inequity. And that inequity has been with us for a long time. And there are inequities on multiple dimensions. People with less education have live shorter, sicker lives. Black Americans have higher burden of disease, lower life expectancy than white Americans, et cetera, et cetera. We know that these are there. These things are unfair. They're inequitable. What the pandemic did is it took those inequities and exposed them. And it's all of a sudden they became part of the public conversation. Everybody on this call knew about these inequities long before the pandemic. There's nothing new for those of us on this call. But the pandemic exposed all of that. Now, the good part about exposing all of this is that all of a sudden I think there's space in the public conversation to tackle these issues in a way that was not there before. And that is the moment that we can capitalize on. That's the moment where you and you on your webinar, everybody on this webinar, I think has an opportunity to shift the conversation in a way that we have not shifted in the past.
Yes, absolutely. And as we do that shift, I want to talk about some longstanding practices that might need to shift. Like, in order for public health practitioners to meet today's public health challenges, what are some of those long-standing practices that must shift? Things like, I just want to hear your perspective, like structural racism. We have increase in community violence. We hear about these shootings almost every day. Of course, we may have another pandemic in the wings. So what are some practices that must shift so we are ready to meet those challenges?
Yeah, look, the range of factors that structure our health. You mentioned structural racism. We can talk about limited education, people who don't have living wages, poor family structures, unemployment, unstable housing, right? All of these forces are forces that affect health. I've written about, and I tell a story, if I may just tell it for just 1 minute, which I find helpful to illuminate these cases, which is the story of Blind Willie Johnson. Some of you on this call may have heard the story. Blind Willie Johnson was, we remember him because he's one of the founding fathers of the blues. And but Blind Willie Johnson was born sighted at the turn of the 20th century, around 1900. He was born sighted. He lost his eyesight in a domestic violence incident when he was age 7. So he was born poor. He was Black. He was blind then. This was in Texas. He was born in Texas, early 1900s, okay? He learned to play the guitar, made a living busking in street corners. Not a very good living, as you can imagine, but that's actually why we remember him. He got married. His house burnt down, so he was living in the burnt out shell of his house. So he was what today we would call unhoused or unstably housed, right? In his early 40s, Blind Willie Johnson got malaria. Now, I mentioned this was in Texas. In the 1940s in Texas, malaria was actually quite common. Some of you may know that the Centers for Disease Control, the CDC, was initially started to help control malaria in the southern states. His wife took him to hospital, and he was turned away from hospital. And then he died. Now, the reason I tell the story is to say, what killed Blind Willie Johnson? Well, at some level, right, it was malaria. Malaria killed him. Had he received treatment for malaria, he wouldn't have died. But when I tell that story, it's clear that malaria wasn't really what killed him, right? What killed him was domestic violence, homelessness, poverty, structural racism, poor access to care. Those 6 factors. And if malaria didn't get him that day, something else was going to get him. We all recognize that. So I tell that story because I say, we could invest billions and trillions into treating malaria. And the Blind Willie Johnsons of the world are always going to live shorter, sicker lives unless we deal with everything else. So our job is to surface the everything else so that we can act on it and make it clear that this is not an argument against treating malaria. I'm using malaria as a metaphor here. I think everybody understands that, right? But it's not an argument against treatment because, when we get malaria, we want the treatment, right? But it's simply an argument to say that the treating malaria by itself is not enough. It's simply not enough, which is why Public Health 3.0, which is what you started with, right, is an agenda that says public health needs to embrace these other forces as part of our remit, not from a discretionary point of view, but because absent addressing these forces, we are never going to achieve the kind of health we want to achieve, right? I think it's an important point that we have to tackle these other forces.
Thank you so much. And I have to let our audience know, Dr. Galea, that we here at County Health Rankings and Roadmaps came up with a series of questions that were kind of circling in our head. We honestly did not expect for you to say, sure, I'll answer whatever, but that's exactly what you did. So thank you so much. So these questions, I want you to know he is just so willing to take some time to tell us his perspective about them. I appreciate that. One of those parts of Public Health 3.0, one of those recommendations, is the need for additional funding, because we are just, we as a sector are really, really stretched, and we're often asked to do more with less. So how do we embrace the future of public health while continuing to provide services that we're mandated to provide, but with less money, less staff?
I don't think we can, actually. I don't have an answer to that, unfortunately. I actually don't think we can. And I think we need to leverage the moment to create momentum for greater investment in public health. And I think at the end of the day, you cannot say public health needs to have a greater scope, but then restrict the funding for public health. Now, I don't want to be negative. I do think there is a moment of opportunity for public health. And I hope that moment of opportunity actually results in real forward motion on this. And I'm not pessimistic. I do think there have been a number of moves towards creating more funding for public health. And I am leaning into hope in 2023. How's that?
I appreciate that. I did not intend to stump you with the question. but
I'm not sure there's an answer. I think
I think you're right.
It's tenuous for us to say to people on this in this audience to say, well, I want you to do more without more funding. I just don't think that's honest, and I don't think that's realistic.
And I'm so glad you said that, because so many of us, particularly those of us who may be in local public health departments, that's exactly what we're asked to do all the time. And so thank you for an honest answer. It's just not really realistic that we're going to have success like that. Now, fortunately, I do know that there has been some government funds recently that's been investing in trying to shore up our public health infrastructure. Tell us from your perspective, how can we best leverage those funds to help guide the future of public health?
Well, I think it's a moment to be strategic about how we use the funds. I mean, for example, there's going to be an infusion of funds around opioid settlement funds, and those opioid settlement funds I've written about should be used to create programs for opioid treatment and prevention, and not diffused away into other infrastructural reasons, to use specifically programmatically for what they're intended to. I think similarly, the challenge historically we have had is, for example, SARS happened, okay? And there was a burst in funding for public health. And when you look at the graph, you see this burst. Then it goes away. And then the trend continues going down. The trick is to use these funds to build infrastructure in a way that it elevates our level of working, and not simply with this episodic bursts, because if it's only episodic bursts, we never improve what we're doing. So that's I think that's our trick. It's how do we make sure that we have funding that are sort of, create a higher bed, a higher level of action of public health rather than simply the episodic infusion.
Yeah, I think that's what it's where we end up. It's just so short-sighted, like you said, those episodes, and we have these bright spots, and it worked really well, but then it's just like there's no continued funding or whatever. So thank you so much for that. I want to encourage the audience. I want to do this before I forget. I want to encourage you to go ahead and get your questions into the Q&A box. So, because we did leave some time, so you can ask your questions of Dr. Galea as well. You have mentioned that public health is political. Ooh, surprise there. But how do public health organizations who are often, navigating complex political dynamics, how do we embrace this in the future, and what's our workaround? What do we do?
Yeah, I think public health is political. Public health has always been political. I mean, it depends, one needs to take a step back and say, what's the meaning of politics? Politics ultimately is about how we collectively allocate resources. That's what politics is, right? And for people interested in this, Dr. Daniel Dawes recently did a book on political determinants of health, which I think is excellent on this topic, much more, broadly, obviously, than what I'm going to talk about here. So I think public health engages with the structures that determine how we spend money, which result then in determining health. Now, we should be careful that political does not mean partisan. Public health is not a blue field. Public health is about the health of populations. Populations are blue and red and purple and green, right? And that means that we need to navigate the politics of resource allocation in such a way that we improve the health maximally of as many people as possible. I saw there's a comment in the chat about sort of ethically allocating resources to those who need them most, and I agree with that completely. There is Julian Tudor Hart, who was a physician about 50 years ago, articulated this, what he called a law, called the inverse care law, which is the people who need help the most are the ones who are least likely to get help. And conversely, people who need help the least are the ones who are most likely to get help. That's the inverse care law, right? The care is delivered inversely to people who need it. We should stop that. We should stop that. We should be putting our resources, our health resources, in the areas and dedicated to the people who need it the most. Now, that's not so easy, right? Because there are these these built-in momentum to how we spend our resources, and resources go in a particular direction in a particular way, and it requires an act of intentionality to change how resources are spent.
Thank you for saying that, and we also are familiar with Daniel Dawes' framework around political determinants of health, and we were fortunate enough to actually be able to interview him for our podcast. So if Colleen hasn't done it already, she probably has already chatted in a link to how you can learn more about our podcast. So you can listen to that interview. It may not have dropped yet, but if it hasn't, I may have given the cat out the bag because we have interviewed him. But Dr. Galea, I want to kind of take us back in history a little bit, because public health found its start in sanitation movements in urban centers like New York City, in London in the 19th century. And even today, sanitation is a basic public health responsibility. Yet we are seeing the rise of unsafe drinking water in urban areas, even today, which is surprising. If you look at some of the urban cores, it's finding its way even in the South, like in Jackson, Mississippi. So how can the future of public health address sanitation and other urban needs? Because we can't, even though we're looking at the social determinants of health, we also have our core responsibilities that we have to meet as well.
Yeah, no, I think that's exactly correct, and I think that's the challenge, frankly, that we face. I mean, you're completely correct that the roots of public health are certainly the sanitary movement in the 19th century in Western Europe, but for thousands of years, actually, in many cultures. I mean, roots of public health. There are public health efforts that have been documented in Africa, in Latin America, in the Middle East, in South Asia, and East Asia, and there are efforts to create clean water in cities, for example. These are all, to create systems to move human waste out of places where people live together. These are thousands of years old, and they are early efforts at sanitation and public health. That remains a core social function for public health. We cannot lose that. Our job is to keep doing that and do that efficiently. And as we do that efficiently, to then be able to add on these other elements without which we realize we're not going to take our health to the next level. And I am hopeful. Again, I said earlier, I'm leaning into hope in 2023, so I'm going to keep leaning into hope that as we get better at some of the, let's call them the basic functions, the core functions, we can do them more efficiently to make sure that we can expand our scope the way it needs to be expanded. I will go back to the point I made earlier. I don't think that expanding our scope is discretionary. I think sometimes in the heat of partisan battle, public health expanding its scope has been characterized as, well, there they go again, talking about things that don't matter. I want to make the point clearly that I don't think treating only malaria will make Willie Johnson healthy. Treating malaria, it doesn't matter if malaria has a treatment. Treating all the malaria without dealing with the unstable housing, with the structural racism, with the poverty, with the lack of access to care, blind Willie Johnson is still going to have a shorter, sicker life than he should have. So dealing with those other factors is not discretionary. So it's not good enough to say, well, if we had to, we can just deal with the malaria. No. Similarly, it's not good enough to say, if we had to, we'll just deal with sanitation. No, we should be able to say, yes, that's a core part of what we do, but the other things are also core parts of what we do.
Yeah, and that's the beauty of Public Health 3.0, because it doesn't leave the past behind. It expands, and it expands in a way that we're able to meet people's needs, not only their most immediate needs, but what's at the core of what's making them sick. And that's the beauty of it. One of the questions that we wanted to ask you is about innovative medical public health partnerships, because we know that partnering is so important. And just was curious about, what are some innovative medical public health partnerships that advance equity? Like, what are some examples of that type of work?
Yeah, I mean, I think there are many such examples, and I'm not going to call out any single one just because I don't want to not call out ones that are deserving. I mean, I think Robert Wood Johnson has actually done a terrific job at funding a number of programs, and I would go to common features. I think the programs that advance equity all have as common features a clear equity at their core, meaning that they start with an assumption that they are going to be acting on delivering services to people who need them most. That's number one. Number two, that they engage communities in partnership with experts and with subject matter resource folks who can together then create structures that can improve health. Number three, I think all of these programs that successfully generate equity target and engage with the full set of factors that ultimately drive health, not simply with disease, but actually. So I think those characteristics, being equity-centric, engaging community and experts, and dealing with the full set of factors that shape health and disease, are characteristics of equity-centric programs.
Yeah, I couldn't agree with you more. So lots of opportunities there, and we always encourage people, all of our practitioners that are in the field of public health. Partnerships are the way to go. It's the way to the best way to ensure success, because we can't do it alone. So we are going to open it up to our audience for questions that Joanne's been tracking in the Q&A box, but I have one more question for you first before we do that. There's a term that we're hearing a lot more about now. It's not a new term, but it's getting a little bit more, we're hearing a lot more, I should say, and that is the commercial determinants of health. Can you help us understand what they are, those commercial determinants of health, and how can we use them to advance equity as we begin to think about the future of public health and how we do our work differently?
Yeah, so the commercial determinants of health refer to the practices of the private sector that may affect health. So the history in the intellectual engagement with the commercial determinants of health is that public health 50, 60 years ago engaged with the private sector really around what I would call unhealthy products, which means cigarettes. We realized cigarettes were a problem, and as a result, public health engaged with trying to figure out how to limit the production and consumption of cigarettes, right? Then there was a public health engagement around unsafe cars and ways to create better, safer cars. So this is an engagement around a healthy product. I think as a result, public health distanced itself from the private sector and started seeing the private sector, with suspicion. The problem is that when you think about what we do in public health, we work to create a context that generates health. Well, the context that we live in is not just created by the public sector. I mean, look around my office, look around yours. I mean, you know, the public sector didn't create the furniture that you and I are sitting on and talking to each other. This all comes from the private sector. So to say that we can just ignore the private sector or treat it as a sort of only harmful is a misunderstanding of how the world works. So then the question becomes, how does one engage with the private sector? How does one engage with the commercial? The word commercial is the one that's emerged. And the question is, how do we encourage private sector partners? How do we incentivize them to do the healthy thing and disincentivize them from generating things that are less healthy, right? Because ultimately, commercial actors, private sector partners, be they small companies or large companies, have a profit motive. So how do we create a context where they are incentivized to do things that generate health and disincentivized for things that don't generate health? Let me give a concrete example. One of the, there's been a lot of discussion around climate change, right? The argument around climate change is very much a commercial determinants of health argument. It is an argument about how do you create incentives so that corporate actors are not generating byproducts into the atmosphere that create pollution, that create a warming planet, that exacerbate people's asthma and all of that. Now, how do you do that? Well, you do that by creating policy incentives and policy disincentives, by creating technological innovation that changes how production happens, that creates public need and public demand for cleaner products, for public opprobrium against polluting industries, right? All of that are efforts to incentivize health-generating private sector action and disincentivize health-harming private sector action. For anybody who's interested in this, with a couple of colleagues, we just produced a book called The Commercial Determinants of Health, which has chapters from a range of authors, which discusses this in, if you're looking for companion books, we talked about Dr. Dawes' book on the political determinants of health. This book is on the commercial determinants of health. They're all these are all subsets, right, of the broader agenda of the social economic determinants of health, but they're different takes on different features. One of them is about political factors. The other one is about the set of commercial factors, all of which ultimately are determining health.
Thank you so much for just being so gracious enough to answer our questions. You've written so many things. There's so many more questions we can ask you, but we did leave some time for our audience, but we didn't want to be totally selfish here. So I am going to ask Joanne to come on screen and just lift up some of those questions that I know have been in the Q&A box, and I will pause a bit.
Thank you. It's been very busy in the Q&A, so I'm just going to have to apologize ahead of time that we're not going to get to everyone's questions, or we may be here for at least another hour. But thank you so much, Dr. Galea, for entertaining some questions from our audience and just really getting our thinking going about a hopeful future for public health. So I'm going to start off. There were some questions around the Public Health 3.0 recommendations, and Patrick, reflected that he feels that a lot of the focus so far is looking at the future of public health from the inside. He says that we know from COVID that much of the criticism of public health stemmed from a failure to meet demands from the outside, the demands of the general public. So in your opinion, Dr. Galea, what is the public now demanding for the future of public health?
Yeah, it's an excellent question. I think the public wants a public health that is able to balance what is the multiple inputs that we all want in our lives. You know, health is a means, not an end. We want to be healthy so we can live. That means that we want to create a public health that allows us all to live. That means being able to appreciate there are trade-offs, that different ones of us may have different values, different priorities. We want to live in freedom from unnecessary disease, but in a way that allows us the personal autonomy to choose how we live. And that's a tricky balance for us to observe in public health. It's always been a tricky balance. COVID has really shown us how difficult it is to strike the balance. So I think the public wants a self-reflective, thoughtful public health, and a public health that looks out for our health, but does that in a way that respects our autonomy. And that is our collective challenge.
Thank you. There was a question, Dr. Galea, about how do we rebuild trust after COVID? What can public health do? Or what are the first and foremost things that we can do to build that trust again?
Yeah, I do think the self-reflection that I'm referring to is essential to build trust. I think starting to be careful and thoughtful about what we've done during COVID that we could have done better, not from the point of view of recrimination, not from the point of view of finger pointing and spreading the blame, but actually from the place of genuinely engaging with how can we do what we do better. And I think it's time for us in public health to start having those conversations. I think, we've been through COVID, and we in public health correctly have called out a lot of the shortcomings of the world around us and of political actors around us. All of that is true. And we should not stop that. But I think there's also a focus on what we have done so that we can do better. I'll put in the chat, I have a book coming out in the fall that tries to do that from my lens. Others will have other books, and I would encourage us all to think carefully about what it is that we can do better and what can we learn from looking back on COVID.
Great. Yes, please do share that link to the book, because it'll be a great resource for all of us. Sticking with the Public Health 3.0 recommendations, Lisa wanted to know if you have any information or if it's been studied. What is the return on investment on pursuing national accreditation for public health? It seems that some local health departments are hesitant to do that or don't have the resources to do it. Is there anything available that shows ROI on accreditation?
Yeah, it's a good question. There are a couple of papers, I don't have them at my fingertips, that are about accreditation. I think, it's one of those topics which I realize, I think reasonable, thoughtful, well-intentioned people differ on. Accreditation ultimately is a way of ensuring that everybody in a particular area has the right skills to achieve to meet the work functions in that area. At the same time, what we do in public health is very heterogeneous, which sometimes makes it feel like, to what extent is accreditation really necessary to achieve all that? So I don't know. I'm actually torn about it, and I stand to be educated by others to see what the right answer is on that.
Okay, fair enough. Thank you. So I'm going to shift. There were a lot of folks thinking about the public health workforce and what that can look like in the future. And Fernando has been working in public health for more than 20 years, and he feels that the field has become perhaps more specialized and in some ways a more isolated field. And he asks, how can we better integrate public health back into communities, into things like urban planning and policy, so that we're tackling root and underlying causes? Is there, a way to that fosters not only a just and equitable recovery from disasters, but to build more resilient communities from the prevention side?
Look, I agree completely. And I think it is, we in public health need to be better at telling our stories. And we want to be able to tell the story of what public health is. I use my example of the sort of Willie Johnston story, and it's just an example I use. And we all have different stories. And I would encourage us to find ways to tell the story of what health is, because I think that's the only way we are going to realize a vision of public health as a big tent that brings under the sort of that brings internally the all the various elements of that we need to engage with, which is urban planning and housing and financial sector and taxation and sanitation and education. All of these sectors are intersect with us in public health, and I think we need to tell the story so that those people in those sectors recognize that public health is their partner.
Great. This is a little bit of a specific question, but it has to do with the public health workforce. And I know it's something that many local practitioners and people in different states are dealing with. And Elaine asked a question about things like interstate compact agreements for public health professionals, so licensed social workers, nurses, flexible cross-state licensing. Why not continue these cross-state licensings to increase access to services?
Yeah, my short answer is I see no reason why not. I think we are stuck in a bit of from a clinical perspective, we're stuck in a bit of antiquated model of state-by-state licensing that I think has really limited interstate movement of practitioners in multiple dimensions. I think we lifted some of those in COVID. We saw that it can be done. I hate to say it, but I can't help but feel that some of the state-by-state licensing requirements are put in place because there are structures to support themselves, and, rather than because they actually serve a real benefit of protecting the public. Licensure should be there to protect the public, right? To make sure that, if I say I'm a surgeon, I'm a surgeon, like I'm, just to be concrete about it, and which I'm not a surgeon, so it's like, but surely a national approach to these things would be beneficial. And I can't help but feel, sometimes I'm asked a question like this. I can't help but feel like 20 years from now, people will say, can you believe that it used to be that way? Because this just seems not right.
Right. There's that hopeful side of you again, Dr. Galea. We appreciate it.
It is the hopeful side of me. I'm trying to stick to it.
Yes. All right. So you talked about different types of partnerships with healthcare, public health and business. And Regina asks, what about partnerships between public health and elected officials, particularly those that maybe don't really get the value of public health? Any sort of suggestions or tips around that?
Yeah, no, I think, I always answer my phone and email to all elected officials. Well, actually, I'm answering my phone and email to everybody, but in particular, I feel like it's important to be partnering with elected officials, with people who are in a position to make change happen. I think we have a responsibility to do so. I think recognizing the political nature of public health, and that a lot of what we do in public health ultimately happens at the policy political level, we have a responsibility to be as open as possible with our colleagues in the public sector. We forget sometimes in public health, people are elected to public office. The vast majority of them don't know anything about health, like at all. Like, why would you know something about health if your entire career has been, let's say, running a brewery, right? It's like, it's not reasonable to say, something about health. So, I find that well-intentioned politicians and people in the public space want to learn. And I think it's our job, our responsibility to engage with them.
Wonderful. So don't be afraid to have the conversation. Yeah. So I see Erica, you popping in. Is that our time for Q&A?
Unless you have a really short one.
Like I said, it would go on for more than an hour based on the questions we have, Erica. So I apologize to those that we didn't quite get to your questions.
Joanne, when I know Dr. Galea is unable to join us, but some of those questions I think we should bring over to the discussion group, because we can kind of just think about them and probably discuss them as a group. What do you think?
Sure, that sounds like a great idea. Folks, we do
Yeah.
encourage you to come over.
Yeah. So, folks, thank you for just, like picking Dr. Galea's brain. I think he actually enjoyed that. So, and Dr.
Very
Galea,
much so.
thank you. Yeah. And thank you for sharing such great resources too. So right now, Colleen is sharing a survey, a link to a survey. We would love to hear from you all about your experience with this webinar and tell us your thoughts. I want you to know that we definitely listen to your feedback and we appreciate it. So please take some time to let us know what you think. About 90% of the nation believes the US has a mental health crisis, with young people suffering the most. And this is according to a recent study with the Kaiser Family Foundation. So join us next month as we explore innovative partnerships to address mental health. We'll hear from Kini An Tinkham and Tinkham. She's with the Maine Resilience Building Network, and I know Kini Anna, she's awesome. I'm so glad she's going to be joining us next month. We'll also be hearing from Dr. Shamila Khan, also from Boston University, coincidentally, but with the School of Medicine. And they'll be both talking about innovative mental health partnerships. Now, we talked about this a little bit earlier, but our podcast in solidarity has new episodes that have dropped. Some people have been talking about it in the chat. I appreciate all the shout outs that came from you about our podcast. I think it's great too, but we have 8 brand new interviews exploring civic health. So check it out with lots of wonderful minds, including Daniel Dawes, as well as others that's in that series about civic health. And if you want to continue the discussion with us, I hope you will, please join the discussion group, and Colleen's chatting out that link right now. And I'll see you there shortly. But I want to tell you, please be sure to stay in touch with us through social media. We also have a newsletter. That's the best way to get information about the work that we're doing, our podcasts, our upcoming webinars. So please make sure that you stay connected with us on that. And before I leave, Dr. Galea, thank you so much. You have been amazing. We love sharing this space with you and just hearing your perspective about the future of public health. Thank you for everything you do. And I want to thank those of you who are on the webinar as well. Thank you for all the work that you do to create equity in the communities where you live. And I will see you all next month.
Thank you, everybody. Bye-bye.